Well, Mikael, thank you for joining us to talk about CGM data. I think you've seen we've done a couple of these conversations up to this point,
Yeah, of course.
just trying to educate ourselves before the Argonaut project launches next month. And I know you've got a ton of experience in this space and also a strong perspective on kind of what's needed. So maybe just to kick us off, can you give us a sense of just who you are, what you've worked on in this domain? We'll start from there.
Sure. So, Mikael Rinnetmäki, living in Finland, have lived with type 1 diabetes for a quarter of a century now, and have been doing some stuff on the open source development space. There's the Night Scout, or We Are Not Waiting development community. So been part of that since 2013. And also since 2014, doing Sensotrend that does bit similar things, but in this regulated space. So as a health tech startup. And we started in Finland. The main driver was that Finland set up the national personal health record system. And what personal health record meant here at the time was a place for all the observations that patients generate from all these wellness trackers. So we generated a platform where different apps can help patients store and manage the data that they themselves produce and govern. And we were one of the first apps to integrate with that service.
That's super interesting. Could I just ask a question about that? If I understand right, it's national infrastructure. It's even provided by the national government, but patients can use their own apps to bring their own data, maybe even many different types of data into that repository.
And fully FHIR-based since 2016. So 2014, when we started, or 13 actually, we had a platform previous to that, and that wasn't FHIR-based, but in 2016, we got kind of introduced to FHIR, and that seemed really cool that there's an international standard. Before that, it was proprietary technology. And then also Smart on FHIR. So that's when we first built integrations to Epic and Cerner to show that, okay, we have this kind of service. We originally built the service for patients and then helped practitioners view the data, but then we wanted to really embed it into the workflow. And so we built Smart App Launch, or Smart on FHIR, as it was called at the time, mechanism to our app.
So I just want to make sure that I've wrapped my head around this concept because we don't have anything like this in the
US.
Unique. It's really interesting. Who decides what sorts of data can be stored in this repository? Like, does each app developer just get to store anything they want? What happens if an app decides it wants to just send 7 terabytes of random numbers every day? Like, what controls or governs the system?
I would say there's too much governance. To me, ideal would be kind of a full FHIR server, and then some kind of discussion. Okay, the app does meaningful stuff, and the profiles are well defined so that you can actually share data between different apps. But here the approach has more been, you need to, as the app developer, develop the profiles and then try to explain to a bunch of people governing the platform why it makes sense to write data in that format. And there hasn't really been any economic incentive to share data. And it hasn't really made it easier for companies like us to integrate with healthcare. That was the original dream, but it still hasn't really kicked off because there's just a lot of red tape, a lot of stick and little carrot.
Yeah, that makes sense. So you like in the app developer role, I understand it. Maybe that's the better way to put it. As in the app developer role, you have to sort of pitch some sort of national governance board to say, this is an important data type, we're modeling it correctly, and then once they approve it, then you can start writing that sort of data into their system.
Yes, after that, there's plenty of certification. So they have Excel files where you need to declare what your app does and doesn't, and then you need to go through security audits and all of that. So I would say completely the opposite to the US patient-facing smart apps, which are, in my view, totally Wild West and free for anybody to do whatever. There you kind of trust the patient to do what's sensible.
Yes.
they can take some app into use.
And when it comes to the national repository, you mentioned aspects of integrating that back into clinical workflows. Was that part of the original design? Is there like a standalone sort of website that clinicians can go to look a patient up, or how does that happen?
Yeah, that's still being discussed. My view has always been, because we started with Smart App Launch, that, hey, the app is responsible for that. So originally, the first integrations we made was with CGM, so the previous kind of context switching standard from HL7. And there we get the context, which practitioner wants to see which patient's data, and we get it through authorized mechanisms, so we can trust it. And then we, as the app, govern that. Okay, I can actually I'll show you the app first, and then the kind of authorization mechanisms, so you can
that's great.
better view.
And as you're doing that, do any of the clinical sites, like do they submit data too, or is it just patient apps that connects the national personal health record?
For this, it's just patients. Patients fully govern that, and we also have the parallel infrastructure for clinical data. So that is the Kanta infrastructure, and all EHRs are mandated to push, not all, but a lot of data into this centralized repository. But anyway, I shared the wrong screen, didn't I?
It's okay, it's all just finished us.
Yeah. Is this now more English to you?
Yeah.
So this is the ambulatory glucose profile. I know it's been mentioned to you before, but anyway, the 2-week summary graph of your glucose levels. And what we see as important right now is that when we embed this is actually a living interactive graph, when you can see, okay, how about the previous 2 weeks? How about the previous 2 weeks? If you make some kind of adjustment to the treatment protocol, then it's important to say that, oh, no, I'm not just doing this for these 2 weeks. And you can also go to individual days and see, okay, what's been happening here? How's the basal insulin, bolus insulin, carb estimates, what kind of activity there's been. If you're using a photo-based meal logging, nutrition logging app, you can get all of that data there. And then we have all kind of different views where you can see, okay, what's the effect of breakfast in the glucose levels and lunch. And so all of this, it's really interactive. And this is really our message, that no, don't just put some summary statistics, or don't put PDF reports into the HR. It needs to be this kind of stuff.
So this is lovely. It's really like an AGP report on steroids with a lot of additional data and functionality. I feel like we're sort of looking at a visualization that's part of a system. Can you say more about what is this screen? Is this something that Sensotrend has built, and who would use it?
Yeah, all of this is the Sensotrend app, and this is mainly for patients, but also for the practitioners that guide them. So it might be a primary care doctor, or a certified diabetes educator, or an endocrinologist. So bit different structure, but essentially the same roles. So primary care, or then specialized healthcare. And it might be a doctor or nurse assisting the patient, because we, especially people with type 1 diabetes, well, or people with diabetes, we live with the condition ourselves for the 99.999% of the time. We need to learn this and manage ourselves.
Yeah. So in the context of this Sensotrend visualization, all of these tools, the underlying data, including the CGM sensor measurements, but also the photographs of the food and the insulin delivery records, all of that is stored in the national repository, and then you pull it together for a view each time?
Yeah, that's how we started. So we use the national PHR, and of course that's really Finnish specific. That doesn't scale. And so after that, we've done integrations to InterSystems, for instance, and that is an EHR with a really true FHIR store and FHIR server. So we can do the same there as well. And then when we've done integrations with Epic and Cerner that don't yet take all this data in, then we've had some kind of a FHIR store next to it anyway. So we've done Google Healthcare API and Azure Health and InterSystems. So just set up some kind of FHIR store where you can store all of this data. And currently, small part of it is in the EHR, but.
Yeah, so I want to explore this a little bit. You've built essentially tools for collecting and visualizing the data, but you'll always persist the data into a FHIR-based store under the hood, and that could be a commercial FHIR store that maybe like in the example of a Google or Azure FHIR server. Who would be deploying it? Who's managing that FHIR server, and on whose behalf when Sensotrend is connected to one of those?
Yeah, depends on the case. So often it's us, but with InterSystems especially, we've had cases where it's some other party hosting the whole EHR or the clinical data repository for the healthcare organization. And then they just authorize our app and we connect there, and somebody else takes care of the storage and all the liabilities related to that.
So in those kinds of deployments, there's typically like one health organization or healthcare system that is sort of sponsoring this work, and they want to give their patients access to Sensotrend as a tool, or that give their clinicians access to it as well. And so they sort of either bring or sponsor a FHIR server to be the back end.
Correct.
And so in your view, let me see if this is correct. Let's say a healthcare organization wants to do that today. They might have to spin up their own FHIR server because maybe they don't have one that can store these data yet. But your perspective would be, it would be great if the EHR they already have and the FHIR server that EHR already includes, if that could support these kinds of data flows, so it could serve as the backend without needing an extra piece in the architecture.
Yeah, I'm flexible. I can live with both, and I can understand. In many of the Nordic countries, the healthcare systems, the big ones, are heavy Azure users anyway. And then the easiest for them might just be to turn on Azure Healthcare API, and then we can use that storage. And it's still easier for us because we don't then need to take all that liability that comes with storing the data. And they are happy to do it for us. But yes, integrating it straight to the EHR would be even greater. And regarding that, we see a lot of, this is by Stanford, by the way, we see a lot of analysis tools, and especially in Finland, there's a high need for healthcare personnel. And it's actually a crisis. We don't have enough people, and we are doing what we can to digitalize the industry. And we are moving towards digital care paths for people with chronic conditions, for instance. And there it's extremely important to get a view on the data so that you can keep those people on the digital care path. But you can see, you can monitor them real time or close to real time, and then notice, okay, now there's some kind of improvement or deformation, and they can call them to the appointment at that time. And there might be SMS messages each month saying that, hey, Joe, seems that you're doing still okay, and keep going. If you need an appointment, respond with A and we'll set you up. So all these kind of that kind of stuff is happening. And the more components you have in your system, the more difficult it gets, I would say. But it's even more difficult if you don't have even that FHIR server, if you just have Epic system, and you would need to do all of that with it if you can't fit all of the data in.
Yeah. Can you talk us through what's on the screen right now? It's a view of data across multiple patients, if I'm understanding the checkboxes right?
Correct. And the reason for this is to allow a clinician to select, okay, which patients should we concentrate on right now? And this, as mentioned, is not our service, so somebody else might explain this better, but you, for instance, may want to concentrate on patients whose time below range is less than more than 4%. So people who have a lot of hypoglycemia. Or you can see that who are just not in range overall. Or then the severe hypoglycemia, are there people with that? And so, and to me, this is kind of the intermediate step. In my view, it will be soon algorithms that do all of this constantly and on the background, but it's hard to make that leap and jump to that algorithm world without first going through these kind of dashboards where it's actually a clinician looking at the data. Okay, seems reasonable, and all of these dashboards will get first kind of more prompting, saying, okay, I make this kind of selection, do you agree? And then at some point the clinician is not required to approve that anymore when the trust increases.
Yeah, I mean, I can see already even just how powerful this kind of relatively manual dashboard will be. But it also strikes me that it has data requirements that are a bit different from the individual patient data requirements. The underlying elements might be the same, but to make this thing run quickly, to make the filters work for the end user, you know, the clinician managing this dashboard maybe requires things to be indexed or stored in a different way. Is that right? Do you know what kind of underlying store this uses?
Not necessarily. So we are currently doing that kind of performance improvements into our system. But for a long time, we've worked with just individual resources. And now we are doing some kind of clinical report, let's say pre-processing. But we've done that with individual CGM readings that are produced each 5 minutes. And you can do this kind of stuff with that kind of data volume.
That makes sense. You could use the feed of individual level data in a sort of stateful pre-processing where you keep the tallies and then use those tallies to drive the dashboard. Okay. I want to cover one other area that you alluded to, which is, you know, in the common scenario where Sensotrend is being deployed, let's say with a cloud FHIR store as the backend where you're keeping the glucose measurements, but also at a health system where there is an EHR that supports smart app launch. Can you talk us through the typical steps that a patient and a clinician would go through to get to the point where the Sensotrend dashboard is showing up inside of the EHR?
Right. We have a kind of a demo for that. And let's say you're a practitioner, right? So this, of course, comes pre-populated when you open your EHR and you want to see Brett's data, and Brett's patient ID is that, if I remember correctly.
This screen that we're looking at now, this is part of the EHR, or this is a smart app?
Exactly, yes. This is usually we do this stuff in batch, so you never see this. But when it's kind of the preparatory stuff, right now you're just opening the EHR with Brett's view. Okay. And when we started with Epic integrations, we had a button, okay, here launch Sensotrend app, and then you could open Sensotrend's view. And the next step was that we actually embedded the view so that if you are endocrinologist treating patients with diabetes, this is your default view, or part of it. Of course, there's a lot of frame and other data surrounding this, but mainly you see the Sensotrend report right away when you launch the view of that patient. However, if the patient hasn't agreed to sharing their data, this is what you see instead. You don't see the graphs. You see that Brett hasn't given you permission to view your data, and then you go ahead.
Yeah, I just want to make sure before we go into the permission workflow, there's something else that happened prior to this point, which is Brett got a prescription for a CGM, and he somehow got his data from his CGM flowing into whatever the backend FHIR server is that this Sensotrend install is using. Is that right? Can you spell that out a little more?
But that you don't necessarily know. You may know it, but it may be handled through other processes in the healthcare organization. It might just be that your endocrinologist, somebody else has put the patient on CGM, ordered insulin pumps, and so on.
Is that because
So,
the data is being aggregated into the national
No.
personal health record? Okay.
No, the point is that Josh, as the practitioner, only sees that, okay, Brett is my patient, Brett is coming in. Okay, Brett has not yet shared Brett's data. So Josh would send Brett this kind of message. And of course, here we can usually do this automatically because we can see Brett's SMS number or email, and we can kind of batch process these when we onboard a clinic. But anyway, if not, then you just send this. And the important point is that we read this token, and then Brett gets this. And when Brett gets this token, they log in to Sensotrend service. And that's kind of the first step. They onboard the Sensotrend, and after that, they can start connecting their data sources. So if Brett, you're using Dexcom CGM, then you go connect Dexcom as a data source to Sensotrend. If you're using Abbott, you connect Abbott to Sensotrend as a data source. If you're using Google Fit, you can connect that. I remember you use Whoop. You can connect that to get your activity data with your CGM data. So this is kind of the practitioner's view. You as a practitioner just invite Brett to share their data. And when they actually get this link, I could show that as well. But anyway, it's just a permission screen that, hey,
Sure.
Josh Mandel from Demo Hospital wants to see their data. Do you accept? And after that, the data flows. And this is kind of the consent process that we currently manage. And it's okay for us for somebody else to manage this. We don't necessarily need to be the only ones that know that this consent exists.
So my camera is doing weird things. It's for some reason using the thermal sensor instead of the image sensor. It got bored. I assume you're seeing that too.
You're not now quite blurred.
Yeah. Okay. Anyways, I apologize. I'm just going to turn it off for now. But I want to understand this upstream process because it has so many implications for the patient experience. So if you take the example of Dexcom or some of these other device vendors, is the patient in this scenario, they're wearing a device from that vendor, they're connecting that device to their phone where they're still running the Dexcom app or the Abbott app. And then from there, it's going to Sensotrend. And then from there, it's showing up in the EHR. Is that the right set of hops?
Yeah, well, you'd go into our system, and then let's switch this to English as well. And here you have different data sources. And you have the OAuth process with most of these. And you say that I want to connect this data source, I want to connect this data source, I want to connect this data source. And usually as a patient, you know what you have access to.
Okay. So a patient would come here sort of after they've already got a CGM up and running and sort of working with the vendor's backend.
Yeah. Well, patient can onboard without a healthcare organization even being present. So they can just first become a Sensotrend user for their own benefit. And after that,
first they would become a Dexcom user, then they would become a Sensotrend user. Is that the right way to think about it?
Yeah, I would say where we operate, most of people with type 1 diabetes already are using some kind of CGM, either from Abbott or Dexcom or Medtronic or from somebody else. So that's kind of, we assume that has taken place already.
Got it. That makes perfect sense. It's a slightly different starting point than we've talked about in some of our previous conversations. So that's helpful to articulate.
Yeah. And for us, it's not important who's kind of prescribed the device and what are the logistics around that. We want to keep separated from that. We just know that, okay, the patients have access to the data and they share the data with us. And that's also an important point because let's say LibreView, Abbott doesn't officially give an API to access the data. And currently we are kind of challenging them in Europe because in Europe we have the generic data protection regulation, and that gives patients access to data portability. So if some company collects data from you that you give them based on consent, as happens here, then you have the right to get that data to you.
Yes. Yeah.
And
this
even
is perfect.
direct. So this is our current discussion with Abbott. We are doing this, and let's see what happens.
Yeah. So
I would be more worried doing this in US. In Europe,
it's really interesting dynamic. We heard about this a little bit in the call with Lucy Ide. So there's this sort of data access rights question under GDPR, and that is playing out. In the meantime, does that mean you can't get the sensor measurements from anybody who has an Abbott Libre? Like you just can't offer that as an input, or do you have some workaround?
Yeah, workarounds. So many of these developed by the open source development community, and some of them developed by us. But yes, you usually can get real-time access to data. It's just whether you can get a contract to do that and whether you can get the manufacturer's blessing. That's
yes.
not
so I know one workaround that I've played with a little bit myself with the Abbott device is the Android Jug Gluco app, which is kind of an amazing piece of software. But for the workarounds that you have in place today, are they connecting to the vendor backend, like to the Abbott system and getting data from there, or are they bypassing that altogether?
Now, well, both. You can, of course, take data into your Night Scout installation and use that as a data source. That's the kind of open source community way of sharing data. But yes, we have direct connections as well.
Okay, and through those direct connections, you're able to get the every 5-minute glucose measurements?
Yeah.
Okay, it's just not officially supported or allowed in some way.
Exactly. Dexcom is they're the nice guy. They can do that, and they've had an open API in US for a long time, and it's worked in Europe, but it hasn't had supported too well. But now they're opening support in Europe as well. So I would upload them and say they are nice guys, but both Abbott, Medtronic, a bit more challenging.
Yeah, it's a really interesting space. I should say that when my camera went off, I also lost access to see both of you guys and the screen share. So if I say something that seems like I'm not aware of the situation, that's why. But Brett, I just wanted to check if there's other areas that you want to dig into before we wrap up here. This has been super interesting.
No, this is fantastic. Will you be at the work group meeting in May or Dev Days in June?
No.
Okay.
Not coming to Dallas this time.
Yeah, no more questions, Josh.
But well, regarding the workarounds, so I think you know that you can download your CGM data as a CSV file.
Yep,
so that's one thing I'd like to propose to the group to study at, because when you do that and then you upload the data, and this is also true with the CGM receivers. So oftentimes nowadays you use your mobile phone as the receiver, but they also have specific reader devices. And this is for people who don't use a smartphone, don't want to use a smartphone, can't use it, and also for kind of privacy-aware foil hat people who just don't want to share their data with the manufacturer. Then you have a receiver device that you use to collect the CGM data. And then we also have an uploader app. That's a computer app that you install, and then you connect to the reader device with CGM. And once you extract the CGM or an insulin pump system, you may get 20 to 50,000 readings at one point, and then you'll upload those to the system. And we've learned that when you do that observation by observation, it takes half an hour or more. And it's much better if you support batch upload, and then it takes 15 seconds or less. And that would be kind of my wish to the Argonaut project. At least don't make it necessarily mandatory, but at least make manufacturers, the vendors, aware of this issue, because the the case here is that you go to the clinic and there a nurse helps you upload your data. And if you then need to wait for 30 minutes before you can actually view the data, that's painful.
Yeah, it's
so
a
batch
great
upload,
point.
highly appreciated.
And with respect to those sort of bulk uploads of individual measurements, if there's tens of thousands, are these cases where it makes sense to use the FHIR observation, what's it called, value sampled data type, where you can include a whole string of time separated measurements in one observation? Or do you see an advantage to wrapping each in its own resource?
For CGM data, we've discussed that quite a few times when we started, but time and time again, we came to the conclusion that no, for CGM data, sample data is not suitable, because we want to filter the data and we want to, it's kind of a rolling window anyway. You could do that for each 2-week period, but that's usually still not what you want.
Yeah, I guess I wouldn't think about it as the final persistence format, but as a part of an uploading story. It strikes me that that could be, a pretty practical way to send, as you say, a couple weeks worth of data in one shot without needing to manage thousands of resources to upload.
But for me, the FHIR bundle is the right way, and not sample data, because I don't think, there are any systems that would extract sample data, and all of the true FHIR servers already support bundles.
Yep.
That's my strong preference.
Cool. Yeah, no, it's a really good perspective. I appreciate that.
The other thing is support for medication administration. So currently, with Apotti, the Finnish Epic installation, we are exploring right back to the EHR, and we can post observations, but as I showed, we support a lot of different data sets. And for the wellness data, we can fetch that on demand from other sources, but if you're using our smart insulin dosing pen or insulin pump, those are, again, devices that don't necessarily have a cloud connection, and then it would be really useful to be able to store those the same way as the CGM data to a FHIR server. And there we can kind of do that with observations, but it's quite complex and tricky. And if we could get support to medication administration, that would be super helpful.
Yes, it strikes me also that given the governance processes that you have in place in Finland, there are going to be FHIR profiles today for all these things. I'm wondering if you wouldn't mind sharing links, even just back in Zulip, to those profiles where they exist already. Yeah,
I can do that.
And so you're exploring write back of medication administration. Have you had success doing write back of any of the kind of other CGM, like the observations back to the EHR FHIR store? I know at the very beginning we talked about storing in Azure or other places, but kind of any direct store with any of the EHRs, or their sidecar, whatever you'd like to call their FHIR server?
Yeah, well, early days, but yes, we are working on that in our own write back exercises with Apotti, the Finnish Epic installation. And yes, we can store individual observations, and even managing line codes has been a challenge. But yes, really looking forward to this initiative, and wanted to make sure whether you know of the iCode project.
Yes, we haven't managed to talk with anyone from iCode yet, but we've read their report, and we've tried to reach out to a couple folks there. If there are any connections that you think we should have to folks who have worked on iCode, we would appreciate introductions, because we have not yet heard back from the outreach.
I also heard of the project this year only, and I submitted my own interest to be part of the iCode 2 project that's supposed to start, but also haven't got any response yet.
Okay. Awesome. Well, thank you so much for taking the time with us today. And of course, if it works, we'd love to have your participation in the project when we launch next month, but we will touch base before then.
Yeah, sure. Really excited to make this kind of more harmonized and standardized approach. It's been sometimes hard to do it on our own, so happy to be in a group doing this kind of stuff.
I'm impressed. You guys have done a lot.
Yeah.
Like,
Well, 10 years and still a startup.
Yeah. Oh, awesome. All right. Well, enjoy your evening. Thank you so much.
Thanks. Have a good day.
Take care. You too.